Hello everyone, how are you? Yeah, hello. Thank you so much for joining this early. I know it's very hard for you to join at this time. So I'll try to upload the video as soon as possible, right? So basically, Dr. Ahmed and Dr. Hamza are not giving me their YouTube channel. Okay. So I'm not getting their YouTube channel. So I'll upload it from somewhere else. Okay. I'll upload it from a new YouTube channel, right? Okay, and I'll make a playlist and I'll just mention the topic names in the video. I won't make a pretty thumbnail and stuff like that or write out everything, but it's gonna contain every single thing that you guys need. Okay. Okay. So first of all, today we are gonna start anemia, right? So first of all, the first thing that we want to know is what is anemia. So anemia basically means when your hemoglobin is low, right? You don't need to remember how much hemoglobin is low. Why? Because you're gonna get it in your exam, right? There's gonna be lab values that this is the normal hemoglobin and this hemoglobin is not normal, and there is gonna be a lot of ranges for the hemoglobin, and that is gonna make things very easy for you, right? So you won't have to do all of the. You don't need to worry about hemoglobin and all of those things. Okay. So with that, let's move forward. So basically, we have three types. So whenever whenever you get a question in USMLE about anemia, the first thing that you want to look at is what's the MCV, right? What's the MCV? That's the first thing that you want to look at, right? You want to look at what is MCV. Okay, so so first thing is MCV. So what's the MCV? So if the MCV is less than 80, then it's microcytic anemia, right? Why is it important to look at MCV? Because in the most of the questions of anemia, the first thing that you want to do is you want to diagnose what kind of anemia it is, whether it is microcytic anemia, if it's normocytic anemia. So if MCV is so basically MCV is denotes as the size of the red blood cell, right? So MCV tells us about the size of the RBC, right? If the size is less than 80, then it means that it's a very small RBC. If it's 80 to 100, it means that the size is normal, right? And if it's more than 100, then it means that the size is very big. Okay. So basically, this is what it means. So first thing you look at is the MCV. If the MCV is less than 80, then it's a microcytic anemia. If it's between 80 to 100, then it's a normocytic anemia. And if it's more than 100, then it's a macrocytic anemia, right? Now you don't wanna go into these details right now, right? Because whenever we do any of the anemias, then we'll go over it, and in the end, we are gonna revise this thing, right? So for now, you can sweep the reticulocyte production index, Menster index as well, and interpretation of iron studies as well, because we are going to incorporate it into here. Right. So first thing that I told you guys is if the MCV is less than 80, then most likely it's a microcytic anemia, right? Then it's a microcytic anemia, right? And then the main things that we have in microcytic anemia are basically four kinds of microcytic anemia. And what are those four kinds of microcytic anemias? So the first one is so the first microcytic anemia is iron deficiency anemia, right? Basically, so have you guys done any EWOL questions with Dr. Hestan regarding this?
No.
Okay, so whenever the question comes and the hemoglobin is low, right? The first thing that I want you guys to look at is the MCV. Okay, so you have decided the MCV is low. Right, if the MCV is low, now you know it's a microcytic anemia. That's for sure. Now, what kind of microcytic anemia it is? So there can be four kinds of microcytic anemia. Iron. The other one could be thalassemia, right? And then there could be thalassemia. Then there could be lead poisoning, right? And then there could be a sideroblastic anemia as well. Okay. So we have these four kinds of anemia, right? Iron, thalassemia, lead, and sideroblastic anemia. Okay. Any questions regarding these? Any
No,
question?
doctor.
Okay. So if that's clear, we'll move forward, right? So The first anemia is the iron deficiency anemia. It's very simple. If you don't have iron in your body, you're gonna have iron deficiency anemia, right? The most common, so how they can test it in a variety of ways, right? The most common ways USMLE wants to test iron deficiency anemia is by giving an elderly patient, right? A 70-year-old male patient, right? Or a 70-year-old male patient or postmenopausal woman. This is important, the postmenopausal woman. Why? Because if a woman, okay, so can premenopausal woman have iron deficiency anemia? If yes, then why? Mm-hmm. Anyone?
Because if she is menstruating and in during periods iron is getting lost.
Yes. So basically, when she's menstruating, she's losing blood. And when there is a blood loss, there is gonna be, so basically with blood loss, you're gonna lose iron, right? Dietary problem and menstruation, right? But once a woman undergoes post menopause, she's not no more losing blood, right? Now, when she's not losing blood, there should be no anemia, right? But if a postmenopausal woman all of a sudden has iron deficiency anemia, or if a 70-year-old male, 60-year-old male has anemia, what does this thing mean? Anyone?
Any abnormal place of bleeding
Mm-hmm.
like gut, like GIT.
Yes. So what happens is that a patient is having occult bleeding. So occult bleeding means that the bleeding is present in some way, somewhere that is very occult, like you cannot see where the bleeding is present, right? So nose normally, you would want you to see this. If an old patient comes to you and that old patient is having bleeding, the bleed is most likely due to colonic carcinoma, right? The bleeding is again most likely due to colonic carcinoma. So keep that in mind, right? Whenever an old patient comes to you, whenever they give you an old patient and they ask, what is this anemia? Like MCV is low and what is the most common cause of anemia? Then it's gonna be, it's gonna be iron deficient, it's going to be an iron deficiency anemia due to colonic carcinoma. And then they're going to ask you, right, what is the next best step that you are going to do in this patient? So you are going to do a colonoscopy in this patient. So we do a colonoscopy in these kinds of patients, right? And when you do a colonoscopy, right, you're going to see what's the problem in these patients. Okay. Now,
Doctor, I have a question.
yes.
uh, if there are no symptoms of the carcinoma present or cancer or tumor present, then also we can go for colonoscopy.
Yes, so basically, this is a very important thing. Colonic cancer usually does not present early, right? You are not gonna have any symptoms. The only symptom of colon cancer most likely is the iron deficiency anemia, which we denote by IDA, right? IDA is the most pertinent cause of colonic cancer, right? So that's why colonic cancer is very hard to detect. So that's why we do colonoscopies in these patients. Screening colonoscopies after at the age of 45, we start doing a colonoscopy, right? So this is important. So that's why we do colonoscopies in cancer patients. So this is first thing, right? So first thing, the most common cause is menstrual bleeding. If a woman is having menstrual bleeding, especially if the menstrual bleeding is heavy, the woman can have iron deficiency anemia, especially. Then secondly, if there is any GI problem, right, like colonic cancer, the patient can have iron deficiency anemia as well, right? So the now comes the most important thing that you guys want to know. That is the lab values, right? This is where they confuse you a lot. So if you are not having so basically for any anemia we have five lab values. For now we'll focus on the first three ones. The number one is iron, the number two is TIBC, right? And the number three is ferritin. Okay, so we have these three values: iron, TIBC, and ferritin, right? So basically, what do each of these do? We want to know, right? So let's first focus on the iron value, right? So if a patient is having iron deficiency anemia, what do you think is going to happen to the iron?
Decrease.
Yeah. So the iron is going to decrease. That is the first thing that is going to happen, right? The iron decreases, right? Second thing, remember one thing. Whenever iron decreases, TIBC is known as the total iron bending capacity, right? So basically, in our blood, we have a protein which is known as the transferrin protein. What does this protein do? This protein transfers iron. So iron is just sitting here, right? So iron is just sitting in the bloodstream. And what does this protein do? This protein is gonna tag, pick up the iron, right? So for example, if you have less iron, right? Uh, will the body, in order to fulfill the demands, will the body produce more transferrin so all of the iron can be picked up, or less transferrin? So if a thing is very precious, right? Yeah. So basically, if a thing is very precious, right, you have very less of that thing present, right? You have very less amount of iron that is present, right? A very low amount of iron is present, right? So now when your body is gonna, what your body is gonna do? Your body is gonna make more transferrin to to pick up all the iron. So no iron is left in the blood, and almost all of the iron is delivered. So remember, whenever iron in the body decreases, the transferrin or iron bending capacity in the body increases. This is the most difficult thing that the students do not understand, right? Whenever your iron levels are going to decrease in the body, TIBC is going to increase in the body. This is the most important thing that you guys want to remember. Okay. Now, pyrotic ferritin. Ferritin is a stored form of iron. What do you think is going to happen to the stored form of iron? Will it increase or decrease when a patient is having iron deficiency anemia?
Decrease.
Reduce. Yes. So these are the lab values that are most important, right? I think I have more times today, right? So we can do some questions as well. Like I know you do it with Dr. Hasnan as well, but we can do some as well. Okay. So again, if a patient is old, then most likely cause is going to be colonic cancer, right? Now, one other thing that is very important is that if a person comes from Pakistan, India, Bangladesh, Nepal, right? Any of these resource limited countries, right? And that person is having iron deficiency anemia. What is the most likely cause of iron deficiency anemia in these countries? If a person comes to US and he's residing in US but he's having iron deficiency anemia still. No, yeah. So that is why I specifically mentioned US. Now he's in US because now the diet is better. He's new in US, but he's still having iron deficiency anemia. Why? This one is not written in first year.
Organisms.
Yes, which one?
Uh,
So this is known as the hookworms, right? So we have
Bookworms.
hookworms. We have, uh,
Encyclostoma.
yeah. So encyclostoma, Necator americanus. We have these
Decatur,
three
yes.
ones. Yeah. So basically, these three organisms also causes bleeding, right? These three organisms also lead to bleeding, right? Yes. So basically, Dr. Asma, these are gonna cause reduced absorption, right? They're gonna reduce the absorption, right? And then the patient is gonna have iron deficiency anemia, right? Now, first, you don't mention other stuff as well. We are gonna. I'm trying to link those as well because today we have time, right? So the next thing is that if a person comes with iron deficiency anemia, right? And the next thing that you guys see in this guy is that this guy is having this guy is having chronic diarrhea, right? This guy has chronic diarrhea, right? And okay, he has failure to thrive as well, right? Hmm. And when you check the patient's IgA levels, they are reduced. What do you think is the most likely diagnosis? Think before you answer. Hmm.
GRDS.
Anything else? I'll tell you one other thing about that GRDS too.
Immunoglobulin A deficiency.
Uh-huh. Yeah, there is IgA deficiency, but what else? What else? I know we haven't studied this disease yet, but I have told you a little bit about it.
CVFD.
Uh-huh, mhm. So basically, this is celiac disease, right? So this is known as the celiac disease, right? So basically, celiac disease is a disease in which you have insensitivity to gluten, right? You cannot eat gluten, right? Whenever you are gonna eat gluten, you are gonna get diarrhea. You are gonna get failure to thrive, right? you're gonna get iron deficiency anemia, because in celiac disease, white iron is not absorbed, right? See, iron is not gonna get absorbed. You're gonna get iron deficiency anemia. You're gonna get diarrhea, failure to thrive. IgA is gonna be very low. You're gonna have all of these problems that are gonna be present, right? With iron, with celiac disease. Is that clear, guys?
Doctor,
Okay.
Hukum, you told Hukum in resource rich countries.
Resource limited countries, resource limited, like Pakistan, India, Bangladesh, Nepal, and
Okay.
subcontinent areas like Indonesia, etc. So okay, so basically these are the main things. Okay, so chronic diarrhea, failure to thrive, IgA deficiency, bone weaknesses, you are gonna have reduced fertility as well. All of these things are gonna cause iron deficiency anemia. All of these, this is known as a celiac disease, and the patient is gonna have iron deficiency anemia because of these things. Any questions till now, guys?
No, doctor.
Okay. So now, now let's move forward then. Okay. One other thing that is very important is that whenever a patient is having iron deficiency anemia, the RDW is gonna be increased. So what is RDW, right? What is RDW and why is it so important? So basically, RDW stands for red cell distribution width, right? Yeah. So there's gonna be variation in RBC size. Some RBC size are gonna be big, some are gonna be small, right? This thing does not happen in thalassemia. So when we'll study thalassemia, we're gonna see how does the RDW remains same, right? Second thing, that very important thing that I used to ignore a lot, but that played a very important role, is that the RI, right? So RI is known as the reticulocyte count index, right? So the reticulocyte count index is going to increase in these patients. That is going to be decreased in these patients. So what is reticulocyte count index? Anyone? What do you think is the reticulocyte count index? Mhm. Anyone, guys? So basically, reticulocyte count index means that the patient's the red blood cells. So basically, this is the bone, right? I'm making a Tom and Jerry bone. This is a bone. In the bone, red blood cells are produced whenever the hemoglobin is low, right? A lot of red blood cells are going to be produced whenever the hemoglobin is low, right? So in the bone, whenever the hemoglobin is low, the red blood cells are going to be produced. This is the first thing that you guys want to remember. Okay, but now important thing is that if a patient is having iron deficiency anemia, then the thing that is going to happen is that the red blood cells are not going to be produced anymore, right? Because you're not going to have iron to produce red blood cells. So reticulocytes are immature RBCs, right? The more immature RBCs you have, it means the more amount of red blood cells are being produced right now, right? So if you have a lot of immature RBC, it means that you are producing a lot of red blood cells, right? If you have less amount of immature RBCs, that it means that your body is not producing red blood cells anymore, right? So again, keep it in mind, right? Immature reticulocyte count index is very important in determining if the patient is having uh, appropriate response or not to anemia, right? Again, if reticulocyte count index is increased, it means that patient's iron levels are normal. But if the reticulocyte count index is decreased, it means that the patient iron levels are not normal, right? Now, how is the patient gonna present to you, right? These were all of the things that are important, but now how is the patient present? Basically, the patient is gonna say, "I'm gonna have fatigue, lethargy, tachycardia. The nails are gonna be like shaped like spoon, right? That's it." So this is everything regarding the main things regarding iron deficiency anemia. Any questions regarding iron deficiency anemia, guys? No. Okay. Now, one important thing, right? So let's look at the lab changes again, right? Let's look at the lab changes, right? So the first thing that decreases in iron deficiency anemia is the ferritin levels, right? So first of all, for example, a patient is having decreased amount of blood, bleed is having bleeding. If a bleeding is happening, right, a lot of iron is being lost, right? So first of all, now you know need iron. So where is the iron gonna come from? The iron is gonna come from the ferritin, right? The stored form of iron, right? It's gonna provide you all the iron, right? So first of all, the iron is going to come from the ferritin, right? Now, after that, mhm, so it's going to come from ferritin. After that, then the iron levels are going to be decreased. First of all, ferritin decreases, then iron level decreases, right? And when iron level decreases, then what is going to happen is that you're going to have the anemia. Then HB is going to decrease, right? Then MCV is going to decrease, right? RI reticulocyte count index is going to decrease as well, right? And then RDW is going to increase, right? And then the transferrin TIBC is going to increase as well. Is everything clear regarding that, guys?
Sir, why is RDW increase? Miss, my question is why is the different size of the RBC?
Mhm. Okay, so before that, let me answer this one. What RI increase? What is RI? So, what is reticulocyte count index? Basically, I told you reticulocyte counts. Reticulocytes are the immature RBCs, right? They are the immature RBCs. When the body is making RBCs, first of all, they make reticulocytes, right? So, when do you think reticulocytes will increase? Anyone?
In anemia.
So basically, yes, whenever there is anemia, the reticulocytes are gonna increase, right? The body is gonna make more reticulocytes. So basically, what you are saying is the reticulocyte count index should increase in every anemia, but that does not happen. Why? Because in order to make reticulocytes, you are gonna need iron, because iron is required for hemoglobin synthesis. So what if a patient does not have iron anymore? What are you gonna do then? Cannot do anything for that patient now, right? The patient won't make any more reticulocytes, and the reticulocyte count index is going to be very, 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 very decreased in iron deficiency anemia. Okay, this again, this is the difference between iron deficiency anemia and thalassemia that we'll look at once again. Okay,
No, doctor, I am asking about
yeah, yeah.
uh, variation in forms.
Mhm. I know. Well, so that well, I was asking, like, I was answering Dr. Aksa's question. Yeah, so I'm gonna go over your question now, right? So basically, what is RDW? So RDW is red blood cell distribution width, right? There is another name for it as well. So the other name of this is known as the anisocytosis, right? Right. So red RDW means in. So basically, what happens is that in iron deficiency anemia, whenever you don't have enough hemoglobin, the red blood cells become small. Okay, you need red blood cells. Red blood cell size depends upon the hemoglobin. And hemoglobin level depends on the iron, because iron is going to need the hemoglobin. So if red blood cells level decrease, right, if hemoglobin level decreases, the red cells size of red blood cells are going to decrease as well. Is that clear till now?
Yes.
Yeah. So what is going to happen is that the lifespan of red RBCs are 120 days, right? When a person starts having iron deficiency anemia, some red blood cells are gonna be still in last, the one which will have hemoglobin, and there are gonna be some cells which will have very less hemoglobin, and then you'll have some cells that will have moderate amount of hemoglobin, right? So you're gonna have different amount of cells with different amount of hemoglobins, okay? And that is why the patient is gonna have anisocytosis or different levels of red blood cells, right? Because you're not having enough red blood cells. So just compare it with a person who is living very luxury lifestyle, right? The person is living a very luxury lifestyle, right? So when the person leads a luxury lifestyle, he needs a so if a person is leading a luxury lifestyle, he's gonna need a lot of money for that, right? But if a person does not have that money every month, right, some months are gonna be very good, he is gonna live a very, very good lifestyle. The patient people are gonna say, oh, he has a lot of things with him, right? But other Other times he's not gonna have any money, right? And he's gonna be very poor, right? So then you are gonna see there's a difference in his lifestyle, or there is a variation, right? And the variation comes due to the fact that he does not have enough resources, right? So these resources are again are gonna come from the fact that these patients have um, are going to come from the fact that these patients have a limited amount of iron, right? So when iron is limited, hemoglobin sometimes is going to be produced, right? Sometimes it's not going to be produced, and this is going to cause all of the problems. Okay, so any questions and any more questions?
Sir, reticulocyte production index is used to correct falsely elevated reticulocyte count.
Mm-hmm. No, we are
Uh,
not. Yes, it was started exactly at 4. Uh, I did not get your point. What are you saying?
Sir, I am saying the reticulocyte production index is also called corrected reticulocyte count, or it is used to correct falsely elevated reticulocyte count. So,
Yes.
sir, my question is,
Mm-hmm.
why is falsely elevated reticulocyte count? What the reason behind this?
Right now, okay, so right now we are not talking about the RPI, right? There are two things. One is known as the RPI, which is the reticulocyte production index, and the other is RI, which is the reticulocyte index, right? Right now we are only talking about reticulocyte count index, right? So basically, when we do thalassemia, then I'll tell you about reticulocyte count production index, right? What does that means? Okay.
Okay, okay.
Okay, it's a different concept, right? Okay, so first thing is that iron deficiency anemia is done. Now we have another. So if the MCV is less than 80, right, the other thing that we can have is thalassemia, right? We can now have thalassemia. So what is thalassemia? So basically, thala thala means blood, and semia means sea, right? So it means a blood. So it means a sea of blood, right? It's a very bad condition. It's a very painful condition for the one who has a thalassemia, right? So thalassemia means blood, right? So basically, what happens in thalassemia is that in thalassemia, okay, so first of all, let's start with hemoglobin. So if you look at hemoglobin, hemoglobin has two alpha chains and two beta chains, right? These chains are linked together. The alpha chains are produced by alpha gene, and the beta chains are produced by the beta genes, right? So again, the alpha genes are produced by the alpha genes, the beta genes are produced by the beta genes. So the alpha genes, so if we have a mutation on the alpha, so let's first of all let's go over the concept of gene. So basically, what is gene? So we have our D. So we have 23 chromosomes. This is one chromosome. This is the other chromosome, right? Okay, so this is one chromosome. So on the chromosome, we have small areas which are known as gene. Each gene corresponds to a protein, right? So they make different protein. So if this gene, alpha gene, is compromised, right, the alpha protein is not going to be made. So the alpha unit, alpha chain of hemoglobin is not going to be made, right? So we are going to have less amount of alpha chains, right? When you have less amount of alpha chains, right, beta chains are going to increase. Is that clear? It's yeah. Okay. So this is a very important concept, right? So they are going to be alpha chains and beta chains. Now alpha chains are going to decrease and the beta chains are going to increase, right? So now when you have a hemoglobin with more amount of beta chains and less amount of alpha chains, the hemoglobin is going to be very unstable, right? The hemoglobin is going to be very unstable, right? These so now what is going to happen is that the increased amount of beta chains are going to intertangle or mangle with each other. They're going to mingle and mangle with each other, right? And when they're going to mingle and mangle, what is going to happen is that these chains are going to be present inside. So hemoglobin is present inside RBCs, right? So if this beta chain is present inside, so we have three beta, one alpha. These three beta are going to mangle with each other, right? They're going to make a destruction inside red blood cells, and the red blood cells is going to get very angry and is going to burst, right? So this is what happens in case of thalassemia. So whenever a patient is having thalassemia, these beta chains, alpha chains are going to precipitate, and then they are going to burst, and then they are going to cause hemolysis. Right? Is that clear? Second thing is that when you are not gonna have alpha chains and beta, you are gonna have less amount of alpha chains. There's gonna be less amount of hemoglobin synthesis, right? Again, you are gonna have less amount of hemoglobin synthesis. You are gonna have decreased amount of any red blood cells production. That is again gonna cause anemia, right? So yeah, these are the two ways anemia happens in thalassemia, right? Clear? Now we have four genes. We have four alpha genes, right? We have four alpha genes, right? One, two, three, four, right? If one of this is damaged, nothing is gonna happen. This is known as the minima. This is known as the alpha thalassemia minima, right? If one gene is damaged, nothing is gonna happen. Okay. If two genes are damaged, right, this is gonna be known as the alpha thalassemia minor. Again, nothing is going to happen in minor, right? There is going to be very mild symptoms if two genes are destroyed. The problem comes when you have three or four that are destroyed, right? So if three are destroyed, right? So if three genes are destroyed, then it's going to be known as the hemoglobin H disease, right? Now, three genes are destroyed, very less amount of alpha is going to be produced, more amount of beta is going to be produced. These beta is going to mangle, and that is going to cause a lot of problem, right? Now, if no alpha chain is present, only beta chains are present, no alpha gene is present, right? This is known as the hemoglobin Bart's disease. This is gonna be so severe that the baby is gonna die inside the mother, right? These are the four types: the thalassemia minima, minor. So again, minima, anemia, minor, H disease, and then we are gonna have the Bart's as well. Okay, so one, two, three, four. No symptoms, very mild symptoms, severe symptoms, and the patient is going to die within the month. This is the easiest way I could explain this. This is very hard, right? I never could never understand it myself. I took a lot of time to understand this for myself, right? But this is the easiest way I could explain it to you guys, right? Any questions regarding this? I hope more people came in at this time, but there are very less people there. Well, well, maybe I'll try some other times. Okay. Everything clear till now? If yes, then we'll move the beta thalassemia. We still have to do the lab values, but I'm gonna explain the beta thalassemia first. Right? Now we have beta thalassemia. So in beta thalassemia, right? Basically, beta gene is gonna be gone away, right? Now there is two kinds of beta mutations. So beta plus mutations, in these mutations, beta gene is gonna work a little less, right? There's still gonna be production, but the production is gonna be a little bit less, right? Not a lot of less, but little bit less. Because it's 3:34 a.m. for so some of us sorry. Yeah, so what I wanted to do was I wanted to make sure some Pakistani students. So I wanted to include the Pakistani students and the Indian ones as well, but they did not. But I don't know. Nobody of them came except for Asma only. Only Asma came, right? I don't know. Maybe some other one as well. Okay. You're so okay. So I thought you were from US. Okay. Okay. So what I can do is, Aksa, don't you live in US? Okay. Okay. So okay, so what I so yeah, I'll try. I'm gonna find some other time that works, right? Maybe. So what if I do 8 a.m. US time, right? 8 p.m. US time, but then it's gonna be 5 a.m. Pakistani time. Maybe you can try 10, yeah, 10, 11 p.m. EST time. It's gonna be 8 in the Pakistan. Maybe then people can come. We can. fix, we can see by trial and error which works the most, right?
Doctor, doctor, hello.
Mm-hmm. Mm-hmm.
Previous time was very good. Many people can join that time.
Which one?
The previous time,
Yeah, so so the thing was I was having nights at that time, right? So I went, so that time, yeah, so that time worked for me because I was having nights so at those times, right? But now I have to go at, so it's 4:30, you can see the time, it's 4:36 a.m. At 5 I have to go and I'll come back at 7 in the evening, right? So I have to go at 5, I'll come at 7. So yeah, so I'll go at 5 and come at 7. So the thing is, I cannot reach in those times. So the only period that is left behind is before 5. So I woke up earlier today at 3:30 so I could teach, and then I'll go and come back at 7. Or the other thing that I can do is that I can start teaching after 7, right? I can teach at after 7. So after 7, if I teach at 7, it's going to be 4 in Pakistan, 4 a.m. in Pakistan. If I teach at 8, it's going to be 5. I can do anytime, right? 10 p.m. Okay. Okay, let's do 10 p.m. EST. Right, 10 p.m. EST from tomorrow. That's gonna work as well. Okay, so, but let's complete this first. So B plus mutations means that 7 a.m. Yeah, the issue of recordings. I'm gonna upload it from other. I'm gonna upload it from another channel, right? Uh, if they don't provide me the link, I'm gonna do it myself, right? I specifically got a good internet connection so I could upload it fast for you guys. Okay. So beta plus gene, so beta plus thalassemia, what is gonna happen is that in beta plus thalassemia the synthesis is gonna be reduced. But in beta not, if there is a other mutation which is known as the beta not mutation, yeah. So if there's another mutation which is known as the beta not mutation, so in beta not mutation, nothing is gonna be produced. No red blood cells are gonna be produced. Okay. No beta genes are gonna beta chains are gonna be produced. Okay. Now we have we have three. So again, we have different types of beta thalassemias. The first one is beta. So in first one, what is gonna happen is that one chain is gonna be reduced. So what does this mean? Can anyone tell me? So we have two beta genes. So don't have three. We don't have four beta genes. We have two beta genes, right? So we can have multiple combinations. So beta. What does this means? Yeah. So this is minor. Why is this minor? So as long as, remember this thing, as long as one chain works, this is known as the beta thalassemia minor. Mild changes are gonna be present in it, right? Because one chain is working properly, right? Now, what happens if one chain does not work and the other chains work very less? So, the chain I'm pointing at, what do you think is going to happen to this chain? So, this, did you guys not get the different genes or chains?
Can you please, Dr. Maz, repeat it again?
Yeah. So, basically, did you guys get the concept? Yeah, it's okay. I'll explain it again. Do you guys know what is a gene? Did you get the concept of gene?
Yes, yes.
Yeah. So basically, beta chains of, so hemoglobin has two chains, alpha and beta. Alpha chains are produced by the alpha gene and beta chains are produced by the beta gene. Okay. So we have two chains, alpha chains and beta chains. Alpha chains are going to be produced by the alpha gene, beta chains are going to be produced by the beta genes. The normal beta chains are the ones that we represent by beta, right? So sometimes there are mutations in these chains, and these chains don't work properly anymore. Then we have to denote them with something else, right? So if we denote them with beta plus, it means that there is a mutation in this chain, there is a problem in this gene, but the problem is not severe enough to cause the stoppage of beta synthesis. The problem just causes one thing, right? It causes, it reduces the formation of beta genes, right? Whenever you see the word beta plus, just it means just make the impression in your mind that there is some problem, and due to that problem less amount of beta chains are being produced, right? This is known as the beta plus gene, right? Now if a person has beta naught gene, right, if the person has this gene beta naught, then it means that this person is not making any beta chains because the the gene does not work anymore. Okay, the gene does not work anymore, and there is going to be no beta genes. Is the genes concept clear till now?
Yes, it's clear now.
So based on these beta chains, one, two, three, four, five, six, we can have different kinds of beta thalassemia. Right now, you don't need to memorize these things. Right, I'm gonna give you the main overview of how do we classify these ones. Right. So remember, as long as one of the beta chains is functioning normally, right? As long as one of the beta chains is functioning properly, right? If they give you any combination in which one beta chain is working, right? It's gonna be a beta thalassemia minor. Is that clear? That's the easiest way to remember this thing. As long as one of the beta chain functions properly, there is no problem in that beta chain. This is known as the beta thalassemia minor. Any questions? So, for example, if they give you this, if they give you beta naught, beta plus beta, right? In both of these, the thing that you are seeing is that one beta is normal. One beta chain is normal and that is functioning. So the patient is going to have normal functions due to that beta chain, right? This is known as the beta thalassemia minor. Yeah. So beta thalassemia is still being produced. Yeah, it's being produced. There's some defect, but that's it, right? You're gonna see that defect, but that's it. You're not gonna have a lot of problems in the not a lot of, you're not going to have a lot of problems in these patients. Okay, now if this is done, then we'll move to the next one, right? And the next one of the beta chains is not going to function, right? So if one of the beta chains does not if there is no normal, so remember in next one, so these is known as the minor one, right? Now let's move to the next one. So what if one there is severely reduced beta function? So how severely reduced beta function can occur? If both chains are beta beta plus, right? So this means that very less amount, this is producing low, this is producing low. Or if there is beta naught or beta plus, right? So basically, if there is no beta that is present, normal beta chain, if no normal chain is present, if no normal chain is being produced, then it's a thalassemia intermediate, right? And then we have the most severe form, right? What is going to happen in the most severe form? In the most severe in the most severe form, both of these are going to be absent. Low beta synthesis is occurring in these people. Okay, any questions? Now the third one is known as the most major one, right? That is the major problem, which is known as the major variant. Any questions? Okay, okay. Now this anemia is so severe, you're going to require a lot of blood transfusion for these patients, right? Beta thalassemia major is the most major form of anemia. You're going to require a lot of transfusions for these patients, right? And when you are going to require a lot, because there's going to be a lot of hemolysis, a lot of cells, alpha chains are going to be present. Major and BARTS is the same. Major is the one for beta thalassemia, BARTS is the one for alpha thalassemia. Okay. Mhm. Now, if this patient is going to be so anemic, you are going to require red blood cells for these patients. When you're going to give these patients red blood cells, so what do red blood cells contain?
Dr. Moaz,
Yes.
I have one question.
So what does it mean like like positive and beta not? What is the difference between these two?
Beta not means that this gene is not functioning anymore. So
Okay.
imagine you have a car. So imagine you have a car, right? And you say this car is trash, right? And somebody asks you how much trash this car is. So you say this car does not work anymore. It won't start anymore. This is this means that the car is car not car zero, beta zero, right? The car is not functioning anymore, right? But if you say that this car is you can I can start the car, I can drive the car, but the car stops everywhere, right? The car stops everywhere and the car breaks a lot and there's a lot of problems in the car. The AC does not work, the car brakes does not work. Whenever you accelerate the car, there's a lot of pauses in the car. Yeah, then this is mean, and this means that the car is beta plus, right? The car is there, right? It works, it starts, but it's not working properly. It's working in a very limited amount of time. Okay.
Yeah, okay. Thank you.
Okay, you're welcome. Now again, you're going to require a lot of transfusions. You're going to give the patient RBCs, yes, more like attenuated. You're going to give the patient RBCs, and when you give the patient RBCs, the patient is going to have iron inside him, right? And when the patient is going to have iron, the patient is going to have hemochromatosis. Yeah, I'm gonna go into hemochromatosis in the GI portion, not now, right? And then the patient's liver and spleen are gonna be enlarged. Why are the patient's liver and spleen gonna be enlarged in case of beta thalassemia? Anyone?
RBCs are destroyed in the spleen. That's why.
Mm-hmm.
Repeat it.
What about here liver?
It is stored ferritin.
Mm-hmm. Anything other? Mm-hmm. Mm-hmm.
I guess stored in liver.
So
So
where is
because of the extra medullary
yeah? So
hematopoiesis,
where is the blood made normally?
Bone marrow.
or
Mm-hmm. The blood is made in bone marrow. There is so much hemolysis in beta thalassemia that the bone marrow cannot alone make the blood anymore, right? Require some other source. So what source do you get? You do another thing. You ask the
the
liver and
liver.
spleen to make blood as well, right? Liver and spleen can make blood as well. Okay. So now liver and spleen are making the blood as well, and that causes liver and spleen to enlarge. Okay. Then in hematopoiesis is going to be so much in the bones, right? The bones are going to get enlarged as well, right? You're going to have skeletal deformities, right? Crew cut appearance, right? The patient is going to have a very different face, right? You're going to have chipmunk face, right? This face. This face is going to be present because the patient is having very increased amount of red blood cell formation in these things, in these areas, right? So this is going to cause the chipmunk faces. Okay. Okay. So after that,
Sir,
this is the
what is the cause of this chipmunk base?
okay. So basically, blood is made in the bones, right? When the bones are not functioning, when there is a lot of hemolysis, you're gonna need blood. And where are you gonna get this blood from? So you get this blood from the facial bones as well. The bones of face also start making blood, and that is what cause the chipmunk faces, right? Okay. Now we are led. Okay. So what are the lab values in thalassemia? Okay. Now what are gonna be the lab values in alpha thalassemia and beta thalassemia? So first of all, the iron levels are gonna be reduced here as well, right? In case of thalassemia, the iron levels are gonna be reduced as well, right? Why normally, like if you're not transfusing, right, then the iron levels are gonna be reduced as well, right? Now, the most important thing is that these patients have a normal these patients are going to have a normal RDW, right? The red blood cell distribution width is going to be normal, right? Other thing that is going to be present in these patients is that iron levels can vary in these patients, right? We have a thing which is known as a Menster index. I'll go into Menster index later, right? And hemolysis count later as well. Let's just skip this for now, right? So let's first do lead poisoning.
Sir, in thalassemia, iron is decreased and TIBC. What about TIBC?
Just remember one thing: whenever iron decreases, just assume automatically what's going to happen to TIBC.
And also ferritin is also decreased in this.
Yes, ferritin is going to decrease as well. Okay.
All is going to decrease. Oh, except TIBC.
Yeah, TIBC is going to be increased.
Okay.
Now we have another thing which is known as the lead poisoning, right? Okay. Now we have another thing which is known. Just give me 1 second. Okay, sorry. So what is lead poisoning? So basically lead poisoning is a disease, right? Basically whenever specifically so a lot of houses in the US were made before 1978, right? A lot of houses in the US were made before 1978, right? So the house I am living at was made 120 years ago or something, right? So a lot of houses were made before. So a lot of houses had lead paint in them, right? When the lot of houses had had okay, okay, so a lot of houses had lead paint in them, right? So when they have lead paint in them, that is gonna cause one, that other is per person works in gun factories or ammunition factories or any of those areas. If a person works in battery manufacturing as well, right, in gun ranges as well, right? So in all of the areas, what is going to happen is that this patient is going to have lead poisoning. This patient can have lead poisoning. Okay. RDW and thalassemia, I'll tell you all about that, right? And that's related to the medicine index. Okay. So then you are gonna have a person, and that person is gonna have a lot of symptoms, right? First of all, they are gonna say a person works in the lead factory, or a family moved to a new house, and when they move to a new house, now all of a sudden the baby started having uh, hand drop, foot drop, right? Abdominal pain, right? Anemia, iron deficiency anemia, right? Here, encephalopathy as well, abdominal pain as well. He had lead lines on his gingiva as well, right? Or on the metaphysis of his long bones, right? All of these things are going to be present in case of lead poisoning, right? So this is how lead poisoning presents. I cannot. We have little time less, right? I won't go into the detail of lead poisoning today. I'm going to do it tomorrow because that's a very important topic, and I think we should do it like separately, right? So we're gonna do lead poisoning tomorrow. I think we'll stop till here today, right? This is thalassemia and iron deficiency anemia, right? And we'll start tomorrow. I'm gonna upload the lecture as soon as I get it. I get it in 10-15 minutes. I'll upload it and send the link in the group. And let's try to have a class today at 8 no 10 p.m. EST as well, right? 10 p.m. EST. Okay.
Doctor, Pakistani time is what?
It's be 7 a.m. Pakistani. Okay.
7
Yeah.
a.m.
Yes. Okay. So take care, guys, and bye bye.